for patient posted for TURP with pacemaker. Major anesthesia concerns includes it patient related because most of the patients undergoing TURP are elderly, so geriatric concerns and the surgery related to TURP in which there is a major fluid shift and related to the pacemaker. Preoperative evaluation. Uh, Apart from routine history and examination of the patient, examination and history related to pacemaker, we should first ask the history why the patient pacemaker was inserted, underlying cardiovascular diseases, and the functional status of the patient, reason for pacemaker, if the patient has had any arrhythmia, and the medication the patient is having, whether the patient is pacemaker dependent or not. And we have to look if the pacemaker has been interrogated within 12 months after insertion. And if with the interrogation reports, we have to note down the pacemaker setting, which is the mode and the proper functioning of the pacemaker, battery life, behavior of the pacemaker to magnet, and the interaction of the pacemaker in related to electromagnetic interference. And the battery life can be detected if there is a variation more than 10 percentage in the heart rate, we can denote that the battery life has been subsided. And related to TURP, we have to ask about the obstruction symptoms, whether the patient has had any fever and also any signs of the heart failure. For laboratory investigations, apart from routine lab investigations, we should do ECG. In the ECG, we have to look for the pacing spikes, whether every P wave or QRS complex is preceded by the pacing spike, and echo and chest X-ray to look for the paced chambers, number of chambers which have been paced. And we should do urine analysis and cross matching also should be done. For optimization, we have to ask the cardiologist opinion, and the pacemaker should be converted into asynchronous mode, synchronous mode. And for this patient, my plan of anesthesia would be spinal anesthesia up to T10 level. Intraoperatively, we have to prepare the OT. We have to make ready the external defibrillator and cardioverter, temporary pacing facility if in case permanent pacemaker fails, and the OR room should be warmed and all the emergency drugs should be kept ready. And the monitoring includes standard ASA monitoring with pulse oximeter, ECG, NLBP, and in case of pulse oximeter, we should do plethysmographic tracing. And ECG should be set to the diagnostic mode instead of the monitoring mode. And we have to do arterial BP monitoring for beat to beat variability, and important is hand-on pulse. And we have to rely upon the pulse rate rather than the heart rate because of the electromagnetic interference intraoperatively. And we should apply defibrillator pads anteroposteriorly more than 10 centimeter from the pulse generator. We should follow restrictive fluid strategy to avoid a fluid overload. And in these patients cannot compensate with tachycardia for hypotension. Surgery related problems for this patient, we should ask the surgeon to use a bipolar cautery, and the cautery time should be limited to 1 per every 10 seconds. And the irrigation fluid should be kept at the height of less than 60 centimeters of water, and the reception time should be reduced to 60 minutes, and the size of the prostate should not be more than 60 grams. We should maintain normothermia throughout the procedure, and we should avoid Trendelenburg position. If in case any arrhythmia happens intraoperatively, we should ask the surgeon to stop the electromagnetic interference. And if in case magnet is applied preoperatively, we have to remove the magnet and we should assess for the rhythm. If there is failure of rhythm to revert even after the removal of magnet, we should defibrillate our cardioverter patient. If possible, we have to take bedside ECG with a paper. Post-operatively, till the pacemaker is reprogrammed, we should keep the patient in the ICU with the defibrillator cardioverter ready, with continuous ECG monitoring in diagnostic mode and pulse oximeter. And blood should be sent for hemoglobin, sodium to rule out the TURP syndrome, and we should routinely do a renal function test. Frequent mental status assessment should be done for a TURP syndrome. That's all.
Very good. So this is a very common question all of you must be aware of. And she rightly said, first thing, whenever a patient with pacemaker comes, we must know what is the indication for inserting the pacemaker in the patient. whether it was a complete heart block, whether it was a sickness, Alzheimer syndrome, and what type of pacemaker it is, a non-pacemaker or a continuous pacemaker, or if it is a simple pacemaker or a cardio defibrillator pacemaker, because there is a slight difference in the functioning of a simple pacemaker and a cardio defibrillator pacemaker, implanted cardio defibrillator pacemaker. So all these points have to be evaluated, and the battery life, and if it is an ICD, that is the implanted cardio defibrillator type, how many shocks have been used, because it reduces the battery life, so that information becomes very important. And as far as taking up any patient for surgery, must always have that setting to be changed to asynchronous mode by application of a magnet, which means automatically the machine will be delivering the current. In case of the heart is not pumping properly, the defibrillate, just like your SAMV taking over when the patient's breath is inadequate. This asynchronous mode is nothing but the pacemaker taking over and trying to stimulate the heart when the rate goes down or up unnecessarily, and try to maintain the cardiac output. So these points are known to all of you, I think, and you should be able to integrate and make a thorough thing. And what is the one point I would like to ask you is, you mentioned spinal anesthesia can be safely given. And if there is a hypotension and the heart rate is fixed, the pacemaker dependent patient who has a fixed heart rate of 74, how will you manage the hypotension in this patient?
Vasopressor, sir.
You have to go for peripheral vasoconstrictor like phenylephrine and try to constrict the vessels rather than rushing in fluid and getting into problem. And supposing patient refuses spinal, can you give GA for the TURP surgery? Is there any contraindication for giving GA?
No, sir.
No, there is absolutely no contraindication. So only thing you have to make sure that the ECG is continuously monitored, and you must be able to diagnose or recognize the pacemaker induced contraction or the spikes happening in the monitor ECG from the natural ones. So the QRS that is following normal, so whether it is an atrial stimulant or a ventricular stimulation, that you should be aware of before you take up the patient, so that you, from the monitor you can uh, successfully watch the function of the pacemaker intraoperatively. Okay, that's the only point that you can add to that. Otherwise, this is the answer for this question is available in all the books, so I don't think I need to present any extra PPT for that. So we'll go for the next question. Is there any other question to be discussed?